We will go on to our next illustrious speaker, Dr. Shawn Kwatra. And Dr. Kwatra, and I want to say congratulations again. Just later in this past March, he became the chair of dermatology at the University of Maryland School of Medicine. He holds the Joseph W. Burnett Endowed Professor ship in that area. And so congratulations. He earned his undergraduate degree from Duke University, his medical degree from Wake Forest, and he completed a residency in dermatology at Johns Hopkins University School of Medicine. I believe was there for about 7 years prior to taking on the chair role at University of Maryland. Dr. Quatra's primary clinical and translational research interest is in the pathogenesis and treatment of chronic pruritus and related health disparities. He has published over 200 peer-reviewed publications and is currently funded by the NIH and multiple other foundations. He also serves on the board of directors of the Skin of Color Society, and it's my pleasure to introduce him as he will be addressing racial disparities in itch. Welcome, Dr. Kwatra.
Thank you so much, Dr. Allen, for having me. And I also have to thank you. Dr. Allen's one of my new chair mentors. So she's been very kind and will continue to be very kind, being a mentor to me. And I just have to say, I've been so impressed with the lineup of the lectures and this whole symposium and the history of it and getting to know more about that. So I think this is just really spectacular. There's not enough of these things. It's such a great service. It's great lectures. Clint just gave a great lecture, and there's so many other great ones. So it's really an honor to speak with all of you about a topic that I think has long been overlooked, and that is itch. Itch is dermatology's #1 symptom. And it's also just a tremendous source of discomfort, quality of life disruption, and oftentimes it's been overlooked. So I'm glad now there's finally a movement going on to better recognize itch and study itch and treat itch patients. Me personally, I'm at the University of Maryland and I treat patients. I also have a laboratory, so I'm going to give a little bit of a different bent also from a scientist's perspective and my clinician's hat. And trying to tease out some of the things that we're seeing at the bedside, some of the differences. So I hope you'll be interested in that. These are my disclosures. And I want to start with showing you guys a little bit about my mindset. So I actually did my residency in Baltimore as well, and in Maryland, and I practice in a very diverse area of the country. And one thing I noticed is that I was seeing many patients, skin of color patients, in particular African-American patients, that were presenting with dramatically uncontrolled inflammatory skin diseases that were very, very itchy. And to me, the presentation of many of these diseases was incredibly distinct. And also the severity was so incredible, because just looking at some of these photographs, you can see that patients have probably received poor care previously. Uncontrolled itch, areas of depigmentation and scarring that's present in these patients. So that was one of the themes that actually first got my attention on this area. I just saw that this patient population in particular had so much more itch, and among the different disorders, greater severity and unique disease presentation. So that's what captured my interest, is at the bedside seeing some of these changes. So we're going to go through different conditions. Two of the hallmarks are actually atopic dermatitis and prurigo nodularis. So I'm going to bring you into my exam room. And this is actually a recent patient that I'd seen. It's a 20-year-old African-American female. So she's had atopic dermatitis or eczema since childhood. And what you can see here on the legs, these areas of dyspigmentation. She's never received proper dermatologic care. When I listened, talking to her, these are some of the things she said. The itch is devastating. Feel alone and miserable. I'm embarrassed to leave my house. I'm scared about my situation. And then there was this urgent plea and this call for help. Can someone please finally help me? And this is a person who's young, she's 20, but she already has areas of what will likely be permanent dyspigmentation from this chronic unchecked inflammation, and in some other patients because of overuse of topical steroids. This is what's happening daily. Every clinic just had it yesterday, and I keep hearing the same story. So I wanted to share that story to help jump off through what I look through with my mind is what is causing all of this. This is something that just thought about from many different lenses. Why is there such uncontrolled itch, eczema, other disorders that's leading to these terrible outcomes, these people suffering so much? In a recent study our group did, we found that the quality of life disruption of having chronic itch is on the level of having chronic heart failure, stroke, uh, chronic kidney disease, all of these major conditions. That's where living with severe pruritus stacks up. And so if you think about all the different domains that may be associated, it actually mirrors society, I think, in some of the disparities we may have in society, if you think about all the different things. So what we see is increased disease, burden of disease, but there's also a risk of comorbidities. But some of the causes may be underrepresentation in clinical trials with novel therapeutics, access to care that's not equitable, certainly different genetics and epigenetics, which can actually be activated by your environment as well and social settings. And then other elements of the environment, smoking, pollution, microbiome. It's actually a combination of a lot of these different factors that come together to explain many of the comorbidities. And I've actually spent the last several years trying to peel this apart with science and then also bringing it back to the bedside. So I'm going to walk us through the different domains that we can see in these itch disorders with atopic dermatitis and then another disorder, prurigo nodularis, that disproportionately affect African American patients. So to start, there are absolutely racial disparities in price. This is the study we did a few years ago, global multi-center study. We looked at itch patients across the gamut around the world, across diseases. You can see atopic dermatitis, bullous pemphigoid, hives or urticaria, lymphoma, lichen planus. Well, pruritus in general is more common in African American patients. But the two diseases that have really significant differences are atopic dermatitis and prurigo nodularis in terms of being more prevalent, in particular in Black patients. Other diseases also, such as CTCL or lichen planus, may be more common, but these are the two diseases that are the most common. And so actually, my laboratory has funding from the NIH to specifically study racial differences in these two diseases, atopic dermatitis and prurigo nodularis, and also differences in biomarkers, therapeutic targets, and mechanisms that I'll go through with you all. So it's not just differences in having itch, it's also differences in the quality of life of that itch. So you can see here, this is a study that's very nice, that's published in our JAD journal. And you can see that if you look at elements of it, so my skin burns or stings, scarring from the condition, this is actually much higher and significant that it's higher in African American patients. And the scarring makes a ton of sense because you have post-inflammatory hyperpigmentation. Some diseases you have actually more papular disease as well, so more fibrosis and remnants of that make it more common. But you also have other elements that tend to show you this disease is much more uncontrolled and maybe of a greater severity. So it drives me crazy and nuts. That is absolutely higher in African American patients. It makes me angry or irritable, depressed, or sad, personality change. I mean, this is a lot of different things here that's just beyond the skin. It's, incorporating many different domains. It's showing that much of this disease is uncontrolled. So Black children in particular are 6 times more likely to have persistent atopic dermatitis. There's a greater financial burden that's associated with this. And then also, Black patients that are hospitalized have greater costs of care, greater length of stay compared to non-Black patients. And when you look closely at eczema or atopic dermatitis in Black patients, you really do see a unique morphology. You can look on the back here and you see hyperpigmented areas and papular disease that's so accentuated here on the hands, especially in young children. You can see perifollicular eczema, which tends to appear with these very small hyperpigmented bumps. And so those are some of the features. Other features you can see is that there's post-inflammatory skin changes that we also saw in our other patients. So this is just such a sad situation. Patient came in to me to see me and had just been mismanaged for so long. And you can see the scarring that's present here. And although I was able to get her controlled later, this is permanent, much of this damage. You can also see side effects of steroid therapy. So patients have excessive non-specific topical steroid therapy, you can see hypopigmentation. So it's both hyper darkening and also hypopigmentation in these patients. There's some more photographs to show how the extensor nature of the disease. The redness or erythema, you can see it may be more difficult to appreciate in these patients, just that degree of erythema. If you look at the back here, you can subtly see it's just hyperpigmented, but you can see just this difference in color gradients. And so actually many of the clinical trials for atopic dermatitis are based on tools like the EASY score or the SCORAD, tools that may rely on subjective assessments of redness. And so that can also be another bias when assessing new therapeutics and their efficacy. This is a Asian patient who has atopic dermatitis and not necessarily fitting into our classical criteria. So you can see that there's some psoriasiform scaling here as well in these patients. You can see more areas of scaling and then this significant thickening and xerosis or dry skin that we see in African American patients. When you look across diseases, you can see classical eczema has a very appreciable erythema. African Americans have more extensor involvement. Asian patients also have this mottled dyspigmentation with psoriasiform scaling. These are all pictures from our recent article that we wrote about eczema and skin of color. You can see again this mottled dyspigmentation, classical eczemas in these anacubital flexural areas, but you can see the differences in presentation that can also lead to delays in diagnosis and also delays in properly initiating therapy. So actually many of our African American patients have been managed on topicals for a long time because I think the actual morbidity of the disease was underappreciated. If you just only go by what you see, sometimes that can mislead you. So I actually ask all my patients with an objective scale about their itch intensity. How itchy are they on a scale of 0 to 10? And that can help quite a bit. So this is the classical criteria for eczema. Let's start way back. So this is many, many years ago. There's two doctors who are very important in the field of atopic dermatitis, Dr. Hanifin from Oregon, Dr. Rajka from Amsterdam, not necessarily the most diverse environments. But these docs were very interested in studying and classifying atopic dermatitis and came up with one of our first classification schemes for atopic dermatitis. You can see here that typical morphology and distribution that they noted was flexural involvement. So in the anacubital fossa, I have eczema too. So these are common areas. Chronic dermatitis, history of atopy, and then these minor criteria also. But I've been struck for a long time that this doesn't seem to capture the diversity of eczema. And if you're taught this way, you're more likely to miss it and not appropriately characterize it. So one thing that we have been working for a while to do, and actually published this recently, is an adopted Hanifin and Rajka criteria for atopic dermatitis that takes into account these unique features of disease that I showed you just now. So you can see for major criteria, in addition to flexural lichenification, well, you can also have papular involvement, lichenification thickening or psoriasiform thickening of the skin in these patients. And then also minor criteria as well, dyspigmentation, psoriasiform scaling, perifollicular accentuation, and secondary papular involvement, a prurigo nodule-like formation. And this is actually a patient who has atopic dermatitis. You can see these intervening eczematous areas, but also has a disease we'll talk about in a little bit later in my talk, prurigo nodularis, which is this thickening, these nodular areas of thickening. And if you think about it, African American patients have a propensity towards more fibrosing diseases. We know about with hair loss and central centrifugal cicatricial alopecia, keloids, scleroderma. I mean, it goes beyond that. So I think it's very important that we recognize these differences. But when we started scientifically studying these areas, we found there was a big void also in classifying these patients. And you'd surmise that looking at the variety of clinical presentations that these patients have, that there may also be significant differences in terms of the molecular makeup of disease in these patients as well. These are just some more photos showing the significant thickening. So areas of lichen simplex chronicus or skin thickening, and you can see those areas of dyspigmentation. So it's not just more disease burden, it's also increases in relevant comorbidities of diseases. So this is a study actually published in the Journal of Allergy and Clinical Immunology that's focused on the atopic march progression in children who have atopic dermatitis to asthma. And you can see here that there were some race-specific risk factors, and the relative risk for asthma was higher developing asthma if you were a Black child versus a non-Black child. And in particular, the race-specific risk factors that seem to mediate these effects also included some environmental factors. So, of course, looking at genetic factors and transepidermal water loss and all of that, but it was actually traffic-related air pollution, cigarette smoke, many of these environmental factors that led to greater progression from atopic dermatitis into asthma. So, what about therapeutics, access to care? I'm sure many of you are aware of the revolution going on in atopic dermatitis right now, where there's just a litany of all these, new therapeutics, and wanting to make sure that there are diverse patient populations that have access to these therapies, that are involved in clinical trials. Are patients getting appropriate care from dermatologists? Well, you can see here in terms of broad access to care, this is a study that we did looking at national ambulatory medical care survey data. You can see that in terms of access and a skin exam, there's much lower access from Black patients to white patients to begin with to a dermatologist. And what does that lead to? What's the picture? What does that mean? Here's a patient who saw me, again, a 62-year-old female, severe atopic dermatitis. She had a huge delay to even get into dermatology. And when she did get into dermatology, she had tons of UVB therapy, steroid therapy, histamines, all those things. We had an FDA-approved therapy in 2017, dupilumab, that has been transformational therapy in terms of safety and efficacy, but that drug was denied for this patient. Methotrexate was contraindicated due to anemia. And this patient presented to us, saying she can't sleep at all at night. And then looking at her neck, again, we're all, many of us are in clinical settings and seeing these patients, and you can see these areas of dyspigmentation. That's probably permanent from inflammation that's not addressed early. See dyspigmentation here. You can see this really significant scaling. Look at that. And xerosis through our body. And our hands are tied. This patient got delayed seeing a dermatologist. And then once she saw us, we have less access to novel therapeutics. So there's actually another study that we looked at, and we confirmed that Black patients in particular with atopic dermatitis are less likely to receive many of our newer therapies, both atopic dermatitis, psoriasis, many other conditions. You can see that there's less access to many of the amazing new therapeutics that are revolutionizing care, which again ties our hands. And so you can look at the clinical trials. We're going to look at different clinical trials. This is for dupilumab, published in the New England Journal. You can see that the percentage was not necessarily representative of the population. Also in JAK inhibitor trial with the drug abrocitinib, you can see lower rates than the population. You can look across at upadacitinib and lower rates of diversity of patients, Black participants. You can see here Um, Again, tralokinumab, that's another drug for atopic dermatitis that's proven IL-13 inhibitor, lower rates than percent of the US population who are African American. This has huge ramifications if we're under the percentages so staggeringly. And this is actually better than what it was. It's still not to where it needs to be because these drug approvals need to have diverse patient populations so we know where they're going to work and can affect so many factors. So let's touch on why a little bit more now. The biology, this is where I'm going to put more of my scientist hat on about the underlying genetics and epigenetics of disease as well and how they relate. So actually, I study and I spend a lot of my time thinking about itch. And if you think about it, you're scratching the skin, but then there's this elegant neuroimmune pathway going on underneath the top layer of the skin. You have these nerve fibers, thinly myelinated A delta fibers and unmyelinated C fibers that can feel its transmission. Then in the dermis, you have a variety of immune cells that are secreting cytokines, chemokines. There's a pathway to the dorsal root ganglion that then crosses over and goes from the spinal cord to the brain and actually projects to various brain areas in the somatosensory cortex and processes itch. And if you look a little bit more closely at where you scratch and zoom into the skin here and the outer stratum corneum along with the dermis, what we're seeing is that there's more transepidermal water loss and differences in ceramides in black skin and pH. But you have direct access from these environmental influences that we talk about, traffic-related air pollution, cigarette smoke, urban microenvironments. There's been studies showing there's a unique urban microbiome as well. So that allows for the entry of microbes and pollutants, immune activation as well, through these keratinocytes that secrete cytokines and alarmins. And then you have sensory nerves that just set off. And this is basically this micro itch scratch cycle. People are scratching a lot, but this is actually what's going on. And it does highlight many of the unique features of black skin. There's larger mast cells, which oftentimes degranulate and release a lot of mediators of itch biology. There's increased and a different diversity of microflora, more water loss and lower pH that are also significant factors. So there have been some emerging studies into the genetics of atopic dermatitis. We knew that filaggrin is a genetic marker associated with atopic dermatitis, but it's actually rarely identified in atopic dermatitis patients. And, this has been something that's actually triggered a lot of questions. And these are basically patients that I'd seen of different skin types. You can see Caucasian patients, African American patients, and you can actually see that the disease looks a little bit different. Classical, as we discussed in the antecubital fossa, erythema in the antecubital and popliteal fossa, and these patients very excoriated, itchy, but in our African American patients, there's just a different level of fibrosis. So it actually triggered us to ask more of a question about the transcriptomics that are behind this disease and the genetics behind this disease. So actually what my lab did is we took skin biopsies from these patients. And what we found in African American patients in particular is that when you zoom in here underneath the skin, you can see that there's more acanthosis, so skin thickening, along with spongiosis, which is our classical marker of atopic dermatitis biology and eczema, that you have these areas of spongiosis. You also seem to have more skin thickening, epidermal hyperplasia. So in our lab, we did biopsies and also did RNA sequencing and staining. And we wanted to test the hypothesis that African American patients may have more broad immune heterogeneity in addition to just the type 2 immune axis, which has often been characterized. And of course, there's differences in type 2 inflammation, but we did find that as well. Type 17 inflammation, Th1 and 22, these other pathways seem to be more involved in African American patients. And so that was a study done by one of our fellows. And you can actually also see, we looked at, data from multi-centers about African American patients and how they have more uncontrolled systemic inflammation. So markers of systemic inflammation are C-reactive protein, erythrocyte sedimentation rate, ferritin, all of these markers were also there. So that's a little bit about the genetics and epigenetics of atopic dermatitis, and then more on the environment, these metropolitan urban areas where air pollution can worsen flares. So definitely that increased exposure to secondhand smoke and air pollution is very relevant for all of our diseases, given that the barrier can be disrupted and there can be easy passage of many of these compounds that can trigger cycles for itch. So we talked about atopic dermatitis, but the disease I'd say I spend the most time thinking about, even more than atopic dermatitis probably, is prurigo nodularis. You can see here these very distinct fibrotic nodules and bumps. And this is what I'll go into. I actually commissioned an artist to draw these pictures because I have a large referral base of these patients. And what I've found is that African American patients with this disease have very large skin nodules. They're incredibly itchy. They're very large, very fibrotic, very difficult to treat, oftentimes unresponsive to current therapeutics as well. This is the story of a patient. This is a 30-year-old female. She's had 2 years of prurigo nodularis, which we classify based on these itchy bumps on the skin, and signs of scratching. You can see, oh my gosh, this is making me itchy looking at it right now. You can see all these scratch marks. I'm sure some people in the audience may be itchy as well. And so this patient, I ask everybody, well, how itchy are you on a scale of 0 to 10, where 0 is no itch and 10 is the worst imaginable? This patient was a 10 out of 10. She tried several things. So phototherapy, narrowband UVB, antihistamines, steroids, topically, topical calcineurin inhibitor. It's also affecting her socially. I'm embarrassed. It's her direct quote. I'm embarrassed by all of these bumps on my body, scratching in public, miserable, tried different therapeutics. So she also went on, I feel depressed and sad, can't sleep, feeling alone and miserable. I don't want to interact with family and friends. So it's tough. These patients are seeing us. And we see a skin disease, but it affects so much more. And so I think amplifying these stories can help us, tell it from the patient's words themselves, so we can give them good therapy. So dupilumab has been revolutionary. Also got approval for prurigo nodularis and has worked in many patients. But there's always some patients that have difficult diseases. A patient who started this therapeutic, and you can see that it did not had a significant improvement. It just took a longer time. The itch didn't get better. So that was really a patient that one of the many patients that I think triggered our investigative arm. So we have more bench to bedside work. And when we see patients clinically, they trigger questions. So one of the questions was, there seems to be a lot more fibrosis going on here. And actually, when you look at the skin biopsies, of course, there is more acanthosis and actually this inducible infiltrate in the dermis as well in African American patients. So greater thickening of the skin and tissue fibrosis in these patients. There's actually very significant increased odds of mortality, in particular in Black patients as well. There's all sorts of comorbidities that are associated with prurigo nodularis, from high blood pressure, hypertension, to chronic kidney disease, HIV, diabetes, atherosclerotic disease, tuberculosis. Many of the inequities that we see and disparities lead to many of the systemic conditions, diabetes and chronic kidney disease and all these diseases having so many disparities. And actually prurigo nodularis is another one of these conditions that reflects larger differences in care. And so you can see here, even among HIV patients, prurigo nodularis is way higher, in particular in African American patients. And you can see that demonstrated here, that it's a true comorbidity. When we looked at chronic kidney disease, the progression of chronic kidney disease actually in patients who had PN was very significant in African American patients as well. You can see that they're much more likely to have progression of kidney disease in these patients. So what about the trials for these patients? Well, similar to atopic dermatitis, underrepresented. You can see here again, missing data around 4% for one of these trials of African American patients in a disease that actually disproportionately we found 3.4 times more likely to happen in an African American patient. Having 4% is very difficult. Another study, very low percentages again. So this is another story of a patient to a 76-year-old female who presented with 10 out of 10 itching, investigator global assessment score of 4, which is over 100 nodules. So she was unable to get therapies, again, because of insurance. She enrolled in a clinical trial that I designed that was only at our site, which was abrocitinib, a JAK1 inhibitor, 200 milligrams daily. And you can see here on her skin that she had very significant improvement 12 weeks later. In this patient, her itch was 0, significant reduction in her nodules. The reason we use a JAK inhibitor is because our group had found that from the blood, circulating blood, peripheral blood mononuclear cells of prurigo nodularis patients, they were secreting a lot of IL-22. As well, we know other cytokines like IL-31 are involved. And so we found a very significant improvement. And there's also changes across immune axes in these patients where there's differences in type 2 inflammation, but also other immune axes. This was all normalized with therapy, which we thought was very significant. And you can see this patient who was treated at baseline, and actually broke my heart seeing this patient because you can see just how significant the fibrosis is and the scarring that she has. But look at that improvement. I mean, in 12 weeks, she completely melted with therapy from this trial that we designed, but those scars are permanent. When we looked at the pathology of this patient, you can see remarkable differences in terms of skin thickening and acanthosis and this dermal infiltrate right here, and how that's in just a few weeks totally evolved. You can see here looking at CD4 T cells and macrophages and memory T cells, just how significant this infiltrate melts as well. So finally, this is another 59-year-old African-American female who's failed all sorts of treatments. And in my lab, we actually also did some molecular profiling. So we found that she actually did not have elevated IL-13 levels. She had a little bit different of a unique presentation here. What we found is downstream, she had increase of a compound phosphostatin-3 that's also involved in itch transmission. So we thought that we actually were finding a unique element in African American patients in particular, STAT3, that controls inflammatory itch. And the reason that's important is because we also recently led, and I helped design this trial globally, a trial for a new agent, nemolizumab, which is a biologic soon to be approved, I think. Phase 3 studies have been performed for prurigo nodularis, which I led, and also in atopic dermatitis, and had very significant improvements in itch. This is just another example of how understanding the biology can really help drive innovation in new therapeutics, integrating all of these different factors that I'm showing. And so the genetics has also been a different angle that we've studied in depth. So our group recently conducted the first genetic sequencing study in prurigo nodularis patients. And what we actually found was a new polygenic risk score. So we actually discovered that patients are more likely, based on their underlying genetics, to develop these nodules or having itching on normal skin. So actually prurigo nodularis is a corollary to itch of unknown origin or just generalized pruritus. That's why you do a lab workup for prurigo nodularis patients, similar to itch patients, because it's genetically encoded, whether you're more likely to have itch on normal skin or itch with skin lesions or nodules. So actually helps kind of the framework of understanding the disease a little bit better. You can see is it more common in African and Asian ancestry, prurigo nodularis, from our work. And we took that a step further. So this is work that our group recently also put up this is work funded by the NIH and the Dermatology Foundation's Color Society, the Society for Investigative Dermatology. So important work where we took biopsies from lesional and non-lesional skin, and we did both the whole exome sequencing and DNA methylation. And so first we wanted to look at somatic mutations. You look at these nodules. So these are the clinical photographs. So when you look at these patients, there's huge fibrosis of these nodules. And then in other patients, there's really not that. So we wanted to see what are the unique elements going on here genetically in these actual lesions. What kind of genes are being activated? What we found is something very interesting. Notch1 in particular, and Notch is actually a very important gene that's involved in fibrosis. So when we looked in African American patients in particular, they had Notch coding that is related to this impaired epithelial to mesenchymal transition that was unique to African American patients. So this is actually one of these patients, very fibrotic nodules, super itchy, that presented to us. You can look at that nodule. That's the one we actually biopsied. And when we looked at it, you can see much higher levels of Notch. So this is involved in the signaling. So you can see that my fellow, Solo Oladipo, who did this study with us, and he did this actual staining, you can see just how increased this notch is in the lesions of these patients. So a reason for the increased fibrosis in African American patients. The next concept is epigenetics. So, it's funny. We're in the lab doing research studies, and then we're in clinic, and epigenetics is a little bit of a link to everything. It links what we're seeing clinically with what we see at the bedside, also to um, differences and injustices in society as well. There have been studies about how epigenetics could help explain racial disparities and even chronic pain. And there's been other studies, as you can see here, about differences in DNA methylation that are associated with systemic racism, actually can activate epigenetic markers. So there's all sorts of diseases where there have been different epigenetics that are explaining some of the diseases that we see. So you can see a conceptual framework for this here, where if you may have adverse childhood experience or socioeconomic status because of societal constructs and situations, then you can actually lead to direct DNA methylation differences. So hyper or hypomethylation, which can lead to differential gene expression, activation, silencing, chronic pain, but also chronic itch disorders. And so that was another element that our lab was very interested in. So we actually did skin biopsies and then did this DNA methylation panels, and have been looking into differential DNA methylation, where we're able to take these biopsies, extract the DNA, do intense profiling. And one of the interesting things we found is that actually by race, we found very distinct groups. This is African Americans, this is Caucasians, this is the overall epigenetic level. You can see a very unique, different expression of the epigenome. So that's just another element. I wanted to make sure I gave everyone a taste of some of the work we're doing at the bedside that could help us explain some of these clinical differences that are so significant. Um, and the final element here is the environment, is building more on the environment and the microbiome. This, I believe, is one of the hottest areas in all of medicine right now. So there's recent studies about telling us about human microbiome and race, and actually the human microbiome variation associated with race and ethnicity can emerge as early as even 3 months of age. The impact of racism on urban below ground biodiversity, that's something that has been in the news more recently too. Differences in the oral microbiome, and then environmental differences in global urban microbiomes. These are all just significant studies very recently being published to show differences in microbiome biology. So this is another thing that we wanted to investigate. So we actually took these patients, a diverse array of these patients, and did swabs both in the skin and in healthy control areas. We again found a distinct microbiome by disease severity, and also by race, where you can see that our African American and Black patients had a very unique cluster in the skin of their microbiome, specifically relating to Staphylococcus. So Staph aureus is actually very tightly associated with type 2 inflammation, and that was much higher in Caucasian patients than our African American patients as well. So this is an example actually of two real world patients and their different distributions. You can see that the staph profile was way higher in our Caucasian patient as compared to our African American patient. What we're finding is, the degree of staph that you have is related to your overall systemic immune polarization as well. So that's what we found, is that in these African American patients, we have a wider array of immune activation that's going on. So that's another study that one of our fellows did. So I just wanted to highlight, looking at this in whole a little bit more about this field because nobody had really cared about prurigo nodularis and studying this topic for a really long time. Actually, the disease was described in 1879 from Dr. Hardaway, and then in 1909 there was also another gentleman who described this condition, Dr. Hyde. And then you can see here, so much time went on. 110 years this went on, and patients were just suffering. It took about 2019 to get, actually NIH involved in this, and they funded us actually to study this. But before, there had been nothing, no study, no research. And finally, we can see how things have picked up. But it also highlights tremendous problems in funding because a lot of advancing these diseases requires significant funding. And you can see conditions like psoriasis, which have now 13, 14, 15 approved therapies, have benefited from over the years massive funding. We're talking about 80 million, 80 to 90 million, close to 100 million here each of these years, even with funded therapeutics. I mean, look at all these other conditions, keloids, which disproportionately affect African American patients, central centrifugal cicatricial alopecia, prurigo nodularis, many other conditions. Very little, very little money and very little progress. So it actually lets us have a lens into these conditions and actually broadly into how if we can help shift funding into these diseases, we'll be able to make some breakthroughs. And luckily with prurigo nodularis, I feel so fortunate that we've been able to research this area, and hoping a lot more other people get involved in it. And I think through great symposiums like this, we'll be activating many future scientists as well. So I do want to thank Dermatology Foundation, Skin and Color Society, who supported a lot of this work that I showed you as well. Finally, I wanted to also go through just a few nuances in treatment. This has been a whirlwind tour from the bedside to the bench and the single cells, and now we're back to the patients. And I think that's obviously the most important. So what are some pearls for the bedside for when you treat these patients? Well, we'll go through things to do, things not to do. I see a lot of patients come to me, and then, I wonder for a while. This is a patient who saw me, and you can see that they have these areas of actually like an amyloidosis. So very itchy as well, but they'd had chronic topical steroid use, and you can actually see these areas of dyspigmentation, that this patient has hypopigmentation from inappropriate long-term steroid use. And then also the patient was not controlled very much so as well. This is another patient who came in, and you could see these areas of erythema. And actually, this patient had been uncontrolled on topical therapies for quite some time. And you can see these areas of redness. But then after this patient was improved, you actually still have, if you look here, one of these areas like this hyperpigmentation that's unique sequelae in skin of color patients in particular. The persistence of that post-inflammatory hyperpigmentation. I have so many patients that because they've been delayed their treatment and they've let this inflammation set in, that then they've been left with post-inflammatory pigment changes that some cases are permanent, in other cases stay for months to years and all of that time. So I think this case and many others highlight a few things. Really early, aggressive treatment. That's the most important, because you want to prevent the sequelae of dyspigmentation in these patients. And then also an appreciation of erythema and redness, and not only trusting your eyes. So if you look at this patient here, you might look at them and say, okay, it's not too bad, but look at after treatment. It's very significant. This patient had very significant redness and inflammation, but it may be more difficult with skin and color patients to appreciate that level of redness, which is a reason why I ask all my patients objective measures. It's a check on myself that I'm not going to be making a judgment, knowing that these patients could have misclassification. So I ask everyone, I say, hey, what's your itch? 0 to 10. I ask actually my friends this too. I ask everyone this. I don't know why. It's my favorite question, but it's very simple. It takes 10 seconds. Hey, how itchy are you? 0 to 10. The last 24 hours. How itchy have you been? And then I can't tell you the number of times I'm just surprised. I'm not seeing much of a rash. They say like an 8 or 9, and then I do a double take. And oftentimes I'm up titrating therapy because maybe I made a judgment. So it's a great check on ourselves, a check of bias, a check of all those things. So I'm a big fan of objective measurements. And itch is a big mediator of a lot of morbidity in our patients, sleep disruption, a lot of factors. So to me, the itch is actually even more important in many cases than the rash that I'm seeing, because that's telling me the patient's suffering, probably interfering with different domains of their productivity as well. Here's another patient. So you can see these areas of the hands where they have this eczema. Actually, I have eczema too, so I've been there. Um, having severe eczema in actually the same area before. And you can see again, after therapy, patient had delayed therapy. And look at this mottled hyperpigmentation, even some areas of hypopigmentation, some scarring. That looks like it may be permanent. And, this is all preventable if we knock it out fast. Another patient, that the one that we saw earlier with the dyspigmentation on her legs, patient still sees me, and it just breaks my heart every time because this is all preventable. I've been given long-term topical steroids, wasn't up titrated to systemic therapy. When we got the patient on a systemic therapy, now we have biologics, we have oral JAK inhibitors, we have other new agents. Dupilumab's FDA approved, which blocks IL-4 receptor alpha. Also, tralokinumab targets IL-13, less efficacy than dupilumab. And then we have oral JAK inhibitors, abrocitinib and upadacitinib, which are oral and they're quick on itch. And you have to do lab monitoring for those agents. And actually just a variety of new agents also being approved as well. So this is all preventable. We don't have to utilize topical steroids as much as we have in the past. There are non-steroidal options that are becoming rapidly available, such as topical ruxolitinib, other agents like that that are fast on itch, and also going to be especially important in skin and color patients to prevent these sequelae of therapy. So just to summarize, itch disproportionately affects African American patients. These racial disparities that we see in our patients are multifactorial. Lots of further study going on. Actually, just defining what are we seeing? What is the molecular biology behind these diseases? Is there a differential response to therapy? Are there precision medicine based tools we can use to help phenotype these diseases, which is some of the work we're doing also, is endotyping and looking for different biomarkers. Some treatment pearls that we went through. So you want to avoid undertreatment to prevent long-term sequelae, dyspigmentation, scarring. Look at the patient, ask them objective questions using itch as a bedside marker for disease severity. That can tell you a lot in that moment. Are they controlled or not? It's very sensitive. And then you want to aggressively target that inflammation whenever you see it to reduce the risk of dyspigmentation and scarring, and trying to minimize where you can topical steroid use, and especially that unique heightened risk of hypopigmentation. I also want to thank all of our funders. This type of work and having a laboratory is really challenging. It's been very challenging for me, but also very rewarding. And now I've moved over to University of Maryland. I'm very proud that, we have several sites, but I'm very proud of the site in particular that we have in West Baltimore, because I believe it's one of the best hubs internationally to study diversity. And so one of the big movements we're doing is bridging a lot of this work with our laboratory and then with the patients we see, and trying to further equity in skin diseases. So it's just really great to chat with you all and share some of our work and clinical observations as well. And I think if we have some time, I'm happy to take some questions.
Thank you, Dr. Kwatra. Very comprehensive. Dr. Kanata, we'll let you go ahead and ask some questions.
Yeah, so the first one was more of a comment, go Tarps, and I'll also
Ah!
chime in and say go Ravens. This second one was a question. If a patient has a successful treatment of prurigo nodularis with dupilumab or alternative drug, and becomes fully healed and is no longer pruritic, will the process repeat if the drug is discontinued?
Yeah, it's a great question. So what we think right now is that the disease is more chronic, but what's unique about it is that prurigo nodularis emerges later than other skin diseases in life. So it emerges in middle age. The average age of disease initiation is probably early 50s. And so there's a variety of factors that we think may be related to it. Our lab studies, in particular, neuroimmune dysregulation. So um, I have several patients who've had very significant stressful events in their life that has triggered their PN. Other patients who've even been triggered by the COVID vaccine or other types of um, things that may be appearing. And most of the cases when it happens, it's chronic. So if you take them off therapy, it's just going to come right back. But there are some cases that after patients are improved, they get better. I always give people the options. I usually get them better, uh, probably for a year, get them totally disease free. And then we use shared decision making and talk about goals with the patient. And we can often taper back. If they're doing injection therapy, then we space out the injections, try to. And if usually the disease will pop back if it can't be controlled. And if they're taking oral therapy, we can decrease the dosage as well and give it a shot. I think there are going to be some other novel therapeutics that have unique MOAs. We know that the memory is very important, immunologic memory. So memory T cells are very important in terms of persistence of these diseases. So there's several drugs that are actually in development, such as OX40 ligand inhibitors that are upstream that may be able to modulate activated memory T cells and other diseases. So I would say we're learning more about this. This is really important. Patients want that. And I know docs want it too, as being able to have remittive effects. But right now, it's usually chronic therapy, although some patients can improve. We don't have much long-term data. At this AAD, I presented the longest clinical trial that's ever been done in using nemolizumab, an IL-31 inhibitor. And that drug actually in its phase 2 study showed about 10 weeks of duration maintaining its response. So, we're learning more, but again, the trials, there's really lacking in clinical trials in a lot of diseases, in particular diseases that affect skin of color patients. We are having a huge problem getting trials activated, getting good scales to be able to study the natural history of these conditions the best way, because you can only do so much in a retrospective study or other types of study. You really need powerful clinical trials to advance our fields.
Dr. Kwatra, this is Dr. Wiley here in Oklahoma City. And I had a question for you. In terms of controlling the pruritus, I recall I've seen a number of patients, even in my caring practice when I started, many years ago, who didn't have their pruritus controlled by basic, itch medication. And from my perspective, that contributed to the increase of prurigo nodularis I saw throughout my career. And what would be your approach and comment on controlling the initial pruritus to prevent progression? First thing. And second thing, for the last 6 years of my career, I worked at a First American clinic. Although I see a number of patients with chronic atopic eczema, as I thought about your presentation, which was excellent, I see very few First Americans with prurigo nodularis. I wonder, have you had any research experience with that particular question?
That last question was about which patient population? Can you repeat that?
First American, Native American.
Yeah, Dave, I am actually I practice in an area here in Maryland where we don't have a large Native American population that we're able to treat. But I would actually totally agree with you, Dr. Riley, with your observation that it seems to be less common, at least from what we know so far. But are different elements like actinic prurigo, which is actually different, just a nomenclature difference that tends to be higher in those Native American populations. For the pruritus in these patients and progression, I'm super aggressive with rapid disease control and shutting it down immediately, because my overall thought process on this is that hardening of the disease and chronicity leads to even solidifying the disease. So immunologic memory is very important. So I'm very aggressive. For prurigo nodularis, I rarely do just topical therapy, go immediately to systemic therapy. We know dupilumab's FDA approved. If not available, methotrexate is excellent, 15 milligrams weekly. That's something that I oftentimes do. We know this nemolizumab will likely be, it's not available now, but it will likely be available later this year. And then if we need it adjunctively, there's always things like gabapentin. In the past, I've done thalidomide, which I'm so glad I won't have to do. Also, JAK inhibitors are becoming more widespread, and actually our group had presented some work on that in addition to what you saw at the phase 2 study of povorcitinib in American Academy of Dermatology. So JAK inhibitors can be really helpful too, but I just think the approach needs to be aggressive systemic therapy in most cases off the bat, especially if you have, say, more than 20 nodules on different body sites. You got to go aggressively because it's very hard for a topical therapy to actually penetrate these skin nodules because they're so thick in terms of depth of lesions.
Thank you.
Dr. Kwatra, is there association with macular amyloidosis, the hyperpigmentation that you may see many times on that upper back region, or any question if that's involved with persistent hyperpigmentation that you have as well in the atopic population?
Yeah, no, it's a great question. Yeah, I think macular amyloidosis definitely can contribute. I think it's probably all part of the sequelae of PIH following it. So I know that, say, for notalgia paresthetica, sometimes you can have that secondary macular amyloidosis as well. So I think for eczema, it's probably more of the melanin deposition, but also for other forms of itch, I think that's very, very reasonable and certainly a part of it.
Well, I want to thank you so much for an in-depth presentation. Definitely increased our knowledge with regards to itch and health disparities and things that we need to be aware of. Thank you so much for your time, and we hope to have you in the future once again.
Thanks so much for having me. Thanks, everyone. I really appreciate it.
Take care.